A very good morning to all my respected seniors and colleagues. So at the outset, I'd like to thank the AIOS Scientific Committee and the local organizing committee for giving us such a wonderful conference. So this IC is titled Not Another Brick in the Wall, Tips and Tricks of Publication. So basically, the aim of this IC is to provide tips and tricks of publication so that we can immortalize our work through publications, and we can leave our footprints on the sands of time through publications. So today, I, Dr. Subhrangshu, will be speaking on the first step, research hypothesis and data collection. Dr. Sunil Morekar will be speaking on solving the puzzle, statistical tools and data analysis. We have Dr. R.P. Maurya speaking on immortalize your work, writing the research paper and submitting the manuscript. Dr. Honawar will take us through the crowning glory, choosing the right journal and responding to reviewers. Dr. Chandrima Paul will be speaking on experience counts, writing a review article and meta-analysis. And finally, we have Professor Natarajan sir speaking on the final overview, ethical publishing, financial disclosure, and plagiarism checks. So we start the session. Dr. Chandrima Paul actually has a concurrent presentation, so ma'am will be speaking first. Dr. Chandrima Paul is one of the very first PhDs in ophthalmology in India. She is the Honorary Secretary of the Glaucoma Society of India and President of the Kolkata Association of Ophthalmologists. She is the Director of BBI Foundation Hospitals and has been the Chief and Co-Instructor of multiple sessions in numerous national and international conferences. She takes keen interest in research and publishing and is the Chief Investigator of the landmark Hooghly River Glaucoma Study. She is a key opinion leader in the field of glaucoma. Dr. Paul is also an ardent pianist and a popular debater from her school days at Loreto Convent, Shillong. And she loves traveling and is very passionate in her love for nature. So it's over to Dr. Chandrima Paul, ma'am.
Thank you, Dr. Subhrangshu, for those kind words and having me in your IC. And I'm sorry to jump the queue and disrupt the flow, but as he told you, I have another course to attend. That's the reason. So I'll take you through experience counts, writing a review article, and meta-analysis. At the start, I'd like to tell you that research is creating new knowledge, and we have the editor IGO here, and I think he's taken IGO to a completely different level. I can assure you of that, because we've had numerous articles published in the last 3 years that he has been in the IGO, and it has really been absolutely satisfying experience. And he's really streamlined everything with us reviewers, towing the line of sending things on time. And that's actually what gives the writer or the researcher the impetus to basically publish your work. And thank you very much, Dr. Santosh, for taking IGO to that level. Okay, with that, we move on to the hierarchy of research designs and levels of scientific evidence. So if you look at that, basically, it's a huge pyramid that you have out there. But what we are bothered out here is that basically the primary studies that we do, and then the secondary studies, followed by, there is no pointer here, okay. And finally, when you plan on your primary studies, basically you need to plan on the design. If you have no design, you will not be able to do a study. And that is the starting point. Then I'll move on to literature reviews, under which comes the systemic reviews and the meta-analyses. So a review article, what actually is a review article? Literature review is a survey of previously published research, people who have done research on your topic before you, and that is where actually you can find where you're leading your topic to. So that is a very, very important part of writing an article. So the objective to provide critical evaluation, a new potential research areas that you can actually explore, draw new conclusions, and the other considerations could be provide a comprehensive foundation on a topic, explain the current state of knowledge, identify the gaps which are existing in the potential research, and highlight the main methodologies and the research technologies. So there's this Prisma statement of 27-item checklist for a review article that you have, starting from the title, goes down to the summary, the introduction, and finally the method. Under the method, you have the protocol and registration, eligibility criteria, sources of information, survey, study selection, data collection, data items, risk of bias in the individual studies, summary measures, synthesis of outcomes, risks of basis across studies, biases across studies, and additional analyses. So these actually look a huge long list, but actually when you go through them and do your research article or your review article, it's not really that difficult. Then in the results, you have the study selection, the study characteristics, the risks of bias within the study, results of individual studies, synthesis of results, risk of bias again across the studies, and the additional analysis that you can actually give. In the discussion, you have the summary of the evidence that is very important, which you need to actually adhere to. Limitations, where are your limitations? You should say that, otherwise the reviewers are going to point it out to you, but it's always best to actually admit your limitations. And the conclusion, of course, should be very precise, and exactly what you're aiming at should be available to the reader in those couple of lines or 3 lines that you have. Funding. Funding is a very important part, but that will be dealt by other speakers, so I won't go into it. The structure of a systemic review, again, the introduction, methods, results, and discussion, the normal structure that we follow, that's how it goes into. I'm not going into the details in the interest of time, but just touching almost every steps. So the steps of a systemic review: formulation of researchable questions, select some questions which you are able to answer to, disclosure of studies, evaluation of its quality, and the synthesis. So the review article checklist you have here in front of you. Complete the checklist before you submit your review article. Have you checked the journal's aim and scope? Are you satisfied with that journal where you're sending it to? Because mind you, never send it to 2 journals together. Always wait for one journal to not accept your work and then go into the next. Have you defined the scope of your article? Did you use multiple research search engines to find all that has been written about your topic by others? Have you written a descriptive title and abstract using keywords? When people type one particular word, your article should be able to be traced. Did you start with an overview of the topic? Have you presented a critical discussion? Have you included future suggestions for research in your conclusion? Have you asked a friend to do a spell check and a grammar check? Mind you, that is very important, because very often when we review an article, we send it back because half the article is in past tense and half is in future or present tense. So that is very important. English is important here. And plagiarism, of course, you have to go through it, but nowadays you have various plagiarism checks which are available on the net free of cost. You can download one of those and actually get your plagiarism check done. So to summarize, should be a balanced discussion and evaluation of the strengths. If your critic is more positive than negative, then present the negative points first and then the positives last. And if your critic is more negative than positive, then it should be obviously vice versa. So then we move on to meta-analysis. Meta-analysis refers to the analysis of analyses. The history I wouldn't go into, you can read it up actually. So meta-analysis, as you see out there, is a statistical procedure for the synthesis of the results of several independent studies. Studies must be combinable. So meta-analysis is an observational study of the evidence and can be performed when there are multiple scientific studies addressing the same question, with each individual study reporting measurements that are expected to have some degree of error. So that's again the pyramid that you have out there, meta-analysis right at the top, evidence-based research that is. And you have the Potsdam International Consultation on Meta-Analysis, where systemic reviews, or overviews I would say rather, the application of scientific strategies that limit bias to the systemic assembly, critical appraisal and synthesis of all relevant studies on the specific topic. Then meta-analysis, or the quantitative review, a systemic review that employs statistical methods to combine and summarize the results of several studies. Here I have a table of systemic review versus meta-analysis. So identify and the relevant research study, identify relevant research studies using a defined protocol, the difference between the two, discuss factors that may explain heterogeneity, statistically test study heterogeneity, and investigate explanatory variables, synthesize the knowledge, statistically summarize results to obtain an overall estimation of the treatment effects, not to systemic review necessarily, not all of them include meta-analysis, but all meta-analyses are based on systemic review of literature. That should be very clear. So the basic steps involved in meta-analysis, you have the specific objective, then you have the specific inclusion and exclusion criteria, literature search, that's a quantity assessment and a data collection, followed by sensitivity analysis to testing for bias, and then the analysis of outcome data. And finally, you have the conclusion and recommendations. So application of meta-analysis, that is investigation of adverse effects, new indications for existing therapies, differential effects among subgroups of patients, selection from among several alternative therapies, and shortening the time between a medical research finding and a clinical implementation of new drugs. So summary of the principles, again, meta-analysis should be as carefully planned with a detailed written protocol in advance, a prior eligibility criteria for inclusion of a thorough research for such studies, make high-quality meta-analyses. The graphical display of results from individual studies on a common scale is an important intermediate step, allowing examination of degree of heterogeneity between studies. Different statistical methods exist for combining the data, but there is no single correct method, remember that. But try to choose the most relevant statistical method to your type of analysis. That is what is important. A thorough sensitivity analysis is essential to assess the robustness of a combined estimates of different assumptions and inclusion criteria. The standard outcome measures, this I wouldn't go into detail because I have already explained to you basically what it is. Statistical methods for calculating an overall effect. The last step consists in calculating the overall effect of combining the data, and a simple arithmetic average of the results from all the trials would be giving you misleading results. Remember, please follow the formulas and the protocols which are applicable to your kind of study. A normal arithmetic would not do out there, and that is it basically. So two types of models are used. One is the fixed effect model and the random effect model. The fixed effect model actually provides a weighted average of the series of study estimates, and the random effect is basically a random effect model. We assume that two components of variation, sampling variation, random variation, and our goal in the analysis will be to estimate the mean and the variance of the underlying population of effect studies. Advantages of meta-analysis, I wouldn't go through the details, I've already explained to you. And limitations of meta-analysis also I have told you. But remember this, that poor designs are also mixed with good ones, which can actually screw up your statistical results. So be careful to leave out the poor designs when you're doing a statistical analysis. Otherwise, that could actually lead you to a not so correct statistical analysis. Badly conducted meta-analysis can always be avoided if the basic principles are adhered to. And again, this is the Cochrane collaboration where you can check all the studies that you've taken in your meta-analysis and find out how relevant or irrelevant they are. So the steps for reviews and meta-analysis: define clearly the questions, search for reliable studies, select the quality by means of clear inclusion-exclusion criteria, extract data from each study and display them clearly, evaluate heterogeneity amongst the studies, calculate the studies of each study, estimating diagnostic accuracy, assess the effect of variation in study validity on the estimates of diagnostic accuracy, interpret the result, assessing how much of the review and meta-analysis can be generalized according to the patient's characteristics. So that's just to show you in a single slide that systemic reviews actually include meta-analyses, but not all meta-analysis could be in systemic reviews. So tips to summarize is one should be careful of meta-analyses that do not opt for a clear or systemic procedure. While creating a systemic review, label or title, one should concentrate on the question that you want to answer. Define and mention your analysis plans well before you begin. And I leave you with the thought that your point of view actually creates your reality. So publish your work to immortalize not only your work, but yourself as well. Thank you very much for your attention.
Thank you, ma'am, for taking us so lucidly through such a difficult topic. Since ma'am will be leaving, anyone has any questions, then sir wants to ask.
Award of IGO this time was won by one of those articles which actually did a study from across India and found out that what it is. But again, as I said, that when you do a meta-analysis, you cannot really take each and every study, because then that will actually screw up your statistical results. So basically, I would do that way, that I would read the statistical results, go on to the conclusion and the methods that they have used, and then try to see if one actually relates to the other, and then I would choose those reviews which actually relate to each other and which are more relevant for the present thing. Yeah, because something, say if you're doing a study with say 30 people and you're doing a study with 300 people, so the two would have absolutely different results because of the bias that was exist because of the number that you have. So yes, okay. So Cochrane is very reliable, actually, very reliable. Yes. Yes. Yeah. 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 So like I'll give a small example of say. Absolutely. Like I'll give you a very small example is that during COVID, say most of the North Indian, I think hospitals saw mucormycosis. So if we concentrated our data of COVID on the North Indian hospitals, then mucormycosis would really come up as one of the main complications of COVID, but that was not so in South India or East India or West India for that matter. So yes, you have to include to keep the balance basically. Yes, absolutely. Thank you.
Thank you for the characteristics of a good research hypothesis. It should be conceptually clear, should be objective. Objective data collection, research activity free from researcher value judgment is very important. Should be specific, relevant. It should be consistent with existing body of theories and research findings. Should be feasible and cost effective. And it should have a profound effect on the research variables which are being taken up for discussion. So what are the sources of hypothesis? So most important source are the theoretical or the conceptual frameworks that are drawn up for that particular study. Of course, another important source is previous research, academic literature, and of course, real life experiences. What are the types of hypothesis? Can be a simple hypothesis or a complex hypothesis. Simple hypothesis initially deals with two variables. Complex hypothesis takes into consideration multiple variables. It can be associative hypothesis or causal hypothesis, can be directional or non-directional hypothesis, and of course the null and the research hypothesis. The null hypothesis or the statistical hypothesis is very important because it states that there is no relationship between the independent and the dependent variables, and the p-value basically either supports or refutes this null hypothesis. Now, the very concept of research hypothesis has come under criticism. Some researchers are of the opinion that it has no positive contribution. It may bias the research and predetermine the outcome. Qualitative researchers also claim that hypothesis should result from investigation, not the other way around. Now coming to the second part, that is the data collection. So if we do not store the data properly, analyze the data properly, we will be like the 6 blind men touching different parts of the elephant. Someone touching the tail thought it to be a rope, someone touching the trunk thought it to be a wall, and so on and so forth. So first, plan out your data collection. Look at the objectives and the scope of the study, the research question, the research hypothesis. What sources of information will you be relying on? The quantitative expression, the measurements and the scales that you're going to use, the techniques of data collection, the unit of collection. Now, if we look at the data collection plan, so basically the flowchart is something like identify the types of data, the research question, the research hypothesis, which goes on to the types of measurements and the variables that you are going to apply. Then comes the instruments, the scales and methods that you are going to use. And at this particular juncture, at this particular step, the concept of the written consent, the informed consent comes in. So once this is done, then we move on to the pilot testing phase. Now, based on the results of the pilot testing phase, either we might have to revise and go back to the previous step, that is the instruments, the scales and methods step, or we can go ahead to the next step, that is data collection forms, preparing them, operational procedures, budget, etc., and finally the implementation of the data collection plan. So what are the sources of data collection? Could be internal sources, external sources. External sources could be primary data or secondary data. Primary data, first-hand data, is obviously more reliable, authentic, because it's not been published anywhere and it's got a higher validity than secondary data. Demerits, of course, it's more time consuming to obtain primary data, cost would be higher, sometimes feedback might be inaccurate, and of course we have to put in a lot of effort to collect primary data. So what are the primary data collection methods? Observation, interview, questionnaire, and schedules. So observation. Observation is something we are not interviewing the respondents here. It's an expensive model. The information provided is very limited and it is not suitable in cases where large samples are concerned. So observation can be structured or unstructured. Structured as in where you're carefully defining the units to be observed and the style of recording the observed information. And it is useful mainly for descriptive research. Unstructured observations are more used in the exploratory researches. Observation can be participant or non-participant observation. Participant observation is if the observer observes by making himself more or less a member of the group he is observing, so that he can experience what the members of the group experience. And then the other way around is the non-participant observation, where the presence of the observer may be unknown to the people he or she is observing. Can be controlled or uncontrolled observation. If the observation takes place in the natural setting, it is uncontrolled observation. And when the observation takes place according to definite pre-arranged plans, then we call it controlled observation. Coming to the interview method. So what are the types of interview? We have structured interview with predetermined questions, unstructured interviews which have the flexibility of approach. We have focused interviews, clinical interviews, and non-directive interviews. In non-directive interviews, we actually encourage the respondent to talk about the given topic with minimal direct questioning. Coming to the questionnaire method of primary data collection. So basically here the questionnaires are handed out, it's filled up, then the questionnaires are collected, analyzed and reported. Questions can be multiple choice questions or closed questions. And then we have the open-ended questions. Open-ended questions actually are designed to permit a free response from the respondent and give the respondent considerable latitude in phrasing a reply. An effective questionnaire should be short, simple, and lucid. There should be a logical sequence. Open-ended questions are best avoided in a questionnaires because they would be difficult to analyze. So it's better to give dichotomous questions or MCQs. Control questions to indicate the reliability of the respondent, and provision for indications of uncertainty like no preference, etc. And there should be brief directions with regard to filling up the questionnaire. And finally, we come to the schedule method of data collection. So it is similar to the questionnaire method, but then we have an enumerator who is specially appointed to fill the schedules. Therefore, it is expensive, but the rate of non-response is much lower. The identity of the respondent would be known, but it's a faster method and it narrows the sample as well. Now coming to secondary data is something which has already been collected by others, journals, periodicals, research publication, official records, etc. It may be available in the published or unpublished form, resorted to when primary data sources or methods are not feasible or inaccessible. Secondary data definitely is quick and cheaper. We can encompass a wider geographical area with a longer orientation period, but it is not fulfilling to the specific needs of the research, and accuracy is poor and not up to the date. Now, getting your data ready. If you're dealing with a very large volume of data, you can actually assign a unique identifier to all the data that you're collecting. You should organize and keep all the forms, questionnaires, interviews with you. Check for completeness and accuracy, and remove those that are incomplete and do not make sense. Recording data, obviously computerized or paper-based. Computerized is faster data availability. Analysis is much easier using computerized data. But of course, you would need the hardware and software backup, cloud support. Paper-based, you can administer to all strata of society, but then definitely it's a longer data collection period, and it can be biased. The results can be biased also. Now, storing data. Commonly used, there are many platforms where you can store data. Commonly, we do use the Excel spreadsheet. We use Microsoft Access for database management, quantitative analysis using software like SPSS, and qualitative analysis like APInfo, InVivo, etc. So with that, I come to the end of my talk, and I will now hand over the mic to Dr. Sunil Morekar, who will be speaking on solving the puzzle, statistical tools, and data analysis. So as Sir gets ready, I'll just shortly introduce him.
So at the outset, before we get our, yeah, sure.
Hello. So Dr. Sunil Morekar is the visiting professor lecturer.
So we can skip the introduction.
Sir is no very important for.
I'll say
sir is the
sirf naam hi kafi hai.
Sirf naam hi kafi hai, bilkul. Absolutely agree. And sir is the reviewer of
so
so many journals.
No introduction. We'll go to the let the presentation talk.
Absolutely.
Okay. So I thank the organizers. I thank IGO. Definitely a brilliant job, and the chairperson of the instruction course. So whether we want to be another brick in the wall, let me tell you that the whole idea was that if you make a publication, you're not just another brick in the wall in the world. But then some of us have presentations in publications in journals, and those publications are also just another brick in the wall. They are absolutely horrible, this thing, including mine. So there are some papers which I have published, but then I have pulled them out, and at international fora I have told people what is wrong with my presentations. So I will tell you this: your job is to find out my presentations and write to me, this presentation of yours is wrong. Right? So what are the appropriate statistics tools to be used? And the data visualization, yet another brick. You can make it 50%, but you can put in your graphs and other things and make it look like, yes, you are, this is what your visualization is. Here we understand that statistics is something that is, there is truth, there is falsehood, and then there is statistics, lies, white lies, and statistics. You can use statistics. You can give me any data, you can give me anything you want to prove. I can potentially prove anything that you want to prove, but that is not how you go about it. You will go about it not out to prove a point, but to figure out, collect data, and then try to come to a point rather than proving your point. So we know that a lot of things happened with COVID and HCQ, and none of them had a Cochrane review or a forest plot, or the study designs were all this thing. And then sometimes we said that HCQ is useful, then we said it's not useful, then we put it in the data, then we pulled it out of study designs. And so many COVID graphs you will see in newspapers, in journals, in reputed journals, which are so misleading. So what is it that you want to know? You want to know what to do in terms of statistics as a tool to find out the truth, not to make somebody believe what you think is the truth. So you are somebody who's inconsequent. Data is data, God, right? So disclosures, financial nil. I do have to say that I am a member of the Cochrane collaboration, and some of the workshops there are paid for, and some of the other things which I'm associated will also have paid workshop. I also work with the Council of Science Editors, where we train editors. So anybody who wants to train himself or herself to become an editor in the future, you can come to us, but these are also paid workshops. This has got nothing to do in terms of financial disclosure. So this is something that we've been working since the last 14 years in different places. So the objectives, there are many objectives. I'm not going to run into it, but broadly you want to identify the type of data and the appropriate test for that data. I'm not going to talk about sample size in detail here, but what inference you get and what are the top Bradford Hill criteria. We say that there is correlation and people say that this is causative. No, there is a difference between correlation and causation. Causation has to follow the Bradford Hill criteria. So let's begin. You are here and I'm still here after 15 years. So I am still at the bottom of the graph. I'm still trying to figure out. There are people like Santosh who probably at the peak of the graph, but then I do realize that when I don't understand statistics, that is what I take in my hand and sit. So the broad topics of research which we normally do, we look at the therapy effect. This is what we will do most of the times in our lifetime. Then we look at diagnosis, validity and reliability, screening when you pick up pre-symptomatic cases. So you do a cross-sectional study, and these are the people who out of them is going to develop cancer, who out of them is going to, so you do a cross-section. So you look at one time, point in time. When you're looking at prognosis, what is going to happen in the future, then you have to have a longitudinal cohort. And when you're looking at causation, you'll want a cohort study, 2 cohorts. One is exposed to something, one is not exposed to that thing, or a case control. Now, most of the time people say that RCT is the gold standard, but every test, every design is useful, because you have to understand that we would not know anything about thalidomide if a case paper or a case report was not there. And you look at Avastin, innumerable case reports. So 1,400 which forced the FDA to ask for a RCT or a randomized control trial for Avastin versus Lucentis. So case reports are also very important. Each one of these study designs is important. So you have RCTs, you have parallel group comparisons. There are 2 groups each entering the study at the same time, receives different things. Paired, you have one group which is similar, same age, same sex, same kind of thing, and it is paired with the other group. Within subject comparison, you are looking at subject assessed before and after the intervention. So what was me before, what was my blood sugar after. So you're pairing within the subject. They can be single-blinded or double-blinded. Double-blinded is something that you most often want to do, but there are some cases in which you will have to have single-blind. Then you can have crossover. So your one group is getting this treatment, timolol, you wash out period, and then go to dorzolamide. Those are crossover studies. And then you have placebo control. Placebo control not always possible, because if I have glaucoma and you are going to put me in a placebo group and I will develop blindness, you can't put me in a placebo group. So placebo group, not always possible. No? Then you want to look at the tails of a test. So you will see that there can be a movement of the variable. So IOP can only go in the higher direction, or can it go into the lower direction also. Height can only increase, I cannot go down. Weight can increase, can decrease. So there are 2 tails of a test. When it can either go up or go down, you use 2 tail test. You cannot use a 1 tail test for a variable which can go up and down. You can have a factorial design which permits the investigation of effects both separately and combined of more than 1 independent variable on a given outcome. Cohort studies when 2 or more groups are selected on the basis of difference to the exposure. So tobacco, no tobacco, right? Or high collared shirts, no high collared shirts, and whether I develop glaucoma, right? So there are 2 groups, 2 cohorts which are similar cohorts, right? And you have case control studies, so you find your case. So many of my things are case control studies. So even when I'm done something like Wolfram, I will compare it with conventional AI which other people have done. So I will find comparative groups and studies. Cross-sectional, like I told you, representative of sample is interviewed, examined or studied to gain answer to a specific clinical question. and case reports and case series. So now when you look at, everybody tells me you should do an RCT. So there are times when I have received an RCT as an ethics committee. So I right now I'm the co-chairman of the ethics committee at AIOC. So many times I get, I have been with UNESCO for the ethics committee. I get a lot of RCTs. Many times the RCT is unethical. You cannot do an RCT. One of the biggest problems here in India was cervical cancer and vaccine, and they wanted to do an RCT. How can you do an RCT? How can you keep somebody away from a vaccine which can save life? So do you want to do an RCT whether vaccine will save a person from COVID? So you put 100 people with no vaccine, 100 people with vaccine, and put them into a COVID ward. You can't do that. So RCT is not always ethical. RCT is not always possible. So you have to choose your study design. There is a fixation or an obsession with RCT, with many of the judges and many of the senior people like us for years. Even I have been obsessed with RCTs. ये तो RCT नहीं है, ये तो prospective नहीं है. So you can do audits and other things like that. So I said this, repeated the slide one more time. Then you have to see whether the study design is sensible. All right, whether specific intervention is considered and what it is compared with, right? So I find out the efficacy of this program with handouts and phone numbers, and then ask people later on. So am I introducing biases? I'm talking into, मैंने सबको आपको देखा है, मैंने बाहर जाके आपको पूछना है कि आपको program पसंद तो आया ना? All right, yes and no, and everybody will say yes. You're forced to say yes, right? So what outcome measured and how? So field, whether it is for a longer time, I cannot say perimetry is better. What is perimetry after 5 years? What is perimetry after 10 years? So how long has it been measured, right? So these are important things. IOP measured at different times. I compare the IOP in the morning with the IOP in the evening. In the evening, the IOPs are low. In the morning, the IOPs are high. And then you say, no, I got a difference. That's not how you do a paper. So at the end of it, the statistics is important. And whatever statistics you use, I'm going to challenge it in every paper, even my own published papers 5 years later. Right? So study design, again one more time, risks and prognosis, case control and cohort. You don't want to do RCTs there, right? Treatment efficacy, yes, you want to do RCT. Diagnostic test, you do paired comparative, you find out sensitivity and specificity. We come to that, right? 2 surgical procedures, I'm just stressing on this again and again. Randomized control trial, evaluate a diagnostic test, cross-sectional study, prognosis and outcome, longitudinal cohort, and case control. So we need a nil. Is time over? So why do we need a null hypothesis? Null hypothesis is you can't do studies for something which is glaring. Now you look at COVID vaccine and you realize that COVID vaccine I have given to 100 people and 90 people did not get hospitalized. And 100 people did not take it and 90 of them got hospitalized. Do I need a study for this? You need a study to identify the subtle differences between things where you don't know. Something which is glaring, you don't need a study. There are many times I find a study which is something which is not necessary in the first place. The visualization itself was enough. So then you look at what are the variables in the study. Now what are the variables that you're studying? So the variables can be numerical, numbers, or categorical, qualitative, right? So the numbers can be discrete. So these are integers, often counts, which can be progression-free years, overall survival, that way. And they can be continuous. So it is IOP, 17, 18, 19, 20. They can be continuous data, right? Or it can be categorical, which is ordinal, which is ordered. He went from stage 1 of the disease to stage 2 of the disease to stage 3 of the disease in an order. Or it can be nominal, which are not ordered. O plus, O positive, A positive. There's nothing ordered about it, right? But it is categorical, qualitative. There are no numbers involved here. So then the discrete data can be binary, 2 choices, yes or no, dead or alive, disease free or not, or categorical, 2 choices which are not ordered. So in this race you will see more this thing, in African race you will see more glaucoma, or you can have ordinal more than 2 choices, like stages of a cancer, 1, 2, 3, 4, or I have given a questionnaire Likert scale, 1, 2, 5, right? Continuous data can be interval, can be ratios. So keep this in mind, there can be ratios and you can compare ratios as well. So type of data, what is this type of data is important because the type of data will define the summary measures. So you have 2 groups before and you will find out the summary measures and you will do a descriptive statistics comparing before entry whether these 2 groups were different altogether. So if 2 groups were different altogether, this was an older population, this was a younger population, and these people died after the intervention, these people did not die. They didn't die because of the intervention, they died because of the difference between the 2 groups. Many of the papers and many of the things that I get, they don't have descriptive statistics at all. So where is your descriptive statistics? Did you compare those two groups before you did the test and find out whether the p-value is significant or not? And this data and the type of data will also tell you what are the tests you will use. So the wrong test used for the wrong type of data, I'm going to point that out, right? So this is data which is mean, median and mode all in the same place. Median, mode, almost the same, right? And this is a very symmetrical graph. So this is what you call as a normal data or a parametric data where parametric tests are applied. This one is skewed. So your mean is there, the median is down. These points, many of them are below this thing, a couple of them are above. So this is a skewed data. This is non-parametric. You cannot apply parametric tests here. I'll come to that. So data A, normally distributed? Yes, normally distributed. Mean, median, mode, all are equal. And like 64, 68% lie here, so on either side. These are distortions or skews towards the right or skews towards the left, positive skew or negative skew. Sometimes you may have a normally distributed looking data, but there is a peak. All the, so what is the mean IOP in most of the patients? 18, 18, 18, 18, 18, 18, 18, 18, 21, 18, 18, 18, 18, 18, 14. So this is a positive kurtosis. You don't want to have this kind of a thing. There's nothing you're trying to prove that, right? So again, the design is appropriate according to the data. Now you find the data and you find out whether you are applying the right, what is the data you acquired and what is the test design you thought of. Then you look at the statistical data, parametric data, continuous. When there is continuous and normally distributed, you will use parametric tests. Non-parametric, continuous data, not normally distributed, or categorical or ordinal data. So when there is categorical or ordinal data, you will use the non-parametric test. When there are two samples, students T is used, right? There are two samples, all right? Mean IOP before, mean IOP after, all right? Or mean IOP in this group versus mean IOP in this group, all right? But when it is paired, so mean IOP before the drug, mean IOP after the drug, in the same individual, before, after, there is a pairing. Then you will use the paired t-test, right? So I see paired t-test used for data which is not paired, wrong. Or I see a t-test for data which is paired, wrong, right? So it's very sensible. And then my own study. Now you have to find this from literature and Google it out and find out with my name associated in it. There is data which is endothelial cell count before, endothelial cell count on day 1, endothelial cell count on day 2, endothelial cell count on day 30, on 3 months. And I have used PET-T 6 times. So PET-T between 0 and 1, PET-T between 0 and 30, PET-T between 1 and 30. So what am I trying to prove? Totally lost, confused. That too when me was into statistics for 5 years. So you see a variation of the data, IOP going up and down, or CCT or endothelial cell count going down or going up. There are multiple data. You will use an analysis of variance, how much variance is taking place. So you'll use analysis of variance, that is ANOVA. So simple thing to remember. So you have multiple data of the same person, multiple data of the same group, multiple data at different times, you will use a ANOVA. All right, don't use a paired T. So when there are non-parametric, which is not normal or ordinal or something like that, you will use chi-square test or Fisher's exact. And for ordinal values, you will use Mann-Whitney U or Kruskal-Wallis. And testing ordinal paired data, you will use the sign test. So pair is a sign. It's a good sign. Pair, couples are, right? So paired sign test and Wilkinson's rank sum test. All right. Now, you have to use non-parametric data. You want to see whether the p-value is significant. Now, you can, I will not run into the details, but a Pearson's chi-square test is used to compare observed proportions. This proportion of people in this group or that proportion of people in that group. You want to compare the proportions. All right. And nominal data, better or worse, dead or alive, right? And often graphically represented as a 2x2 test. Non-parametric of Wilkinson's ranks, again, repeating the same thing. This is again the same thing, so I'm not going to do that. So in short, you want to take one picture of this presentation. This is the picture you want to take. There is numerical data. There are two groups. You use unpaired T. There are more than two groups. You will use ANOVA. If it is paired, you will use the paired T. All right. If it is otherwise, it is non-parametric and numerical data, you will use the Mann-Whitney or the Kruskal-Wallis. All right. If it is categorical data, two groups, chi-square test, Fisher's test. If it is more than two groups, chi-square. All right. So this is what you will do. And if this is what is being followed in your paper, I'm going to put this and take this and look at your paper and realize that this is what it is. So what is the data? Is the data parametric? Is the data paired? Is the data over multiple times? Is the test appropriate? All right. And then these are some examples. We will do this in the panel discussion if there's time. So I'm just going to run. So suddenly an RCT comparing mean IOP following anti-glaucoma drugs in 2 groups by the Friedman test. Is this correct? Incorrect? Suspicious? What do you think? Suddenly from somewhere somebody has used a Friedman test because he used tests to find out कौन से test से positive आएगा और उस test को लगा दिया. So this is very suspicious. All right, that why did somebody suddenly come out with a test which is not normally used by many people, and suddenly he used this, and you ask them for the data and say I will apply the test and find out, right? And so again seeing the same thing, independent samples, parametric, paired T, non-parametric. If it is paired samples, ANOVA, chi-square test if it proportions, McNemar's test if it is compared from proportions from paired samples, and compare 2 continuous variables, you will do the Pearson's coefficient. And non-parametric, you will use a Spearman. All right. So non-parametric है skewed है, इधर उधर भाग रहा है तो spear लेके मारने का. All right. So remember it that way. So if it is non-parametric and you are using 2 continuous variable, इधर उधर continuously भाग रहा है तो Spearman's test, Spearman's coefficient, right? So this is how you remember. Now I'm not going to go again to the this thing. You cannot do subgroup analysis. मैं जब तक मेरे को difference नहीं मिलता ना. Okay, let me look at 30 years old. Let me look at 30.5 years old. हाँ, दोनों में difference मिला. हाँ, so my drug works in people who are 30.5 year old between 2 groups. So I can't do that kind of a subgroup analysis, right? So we'll run across. So sometimes you see confidence intervals, and confidence intervals when they are very large and wide, then that sample is very small or there is a lack of precision. So confidence intervals is what I'm going to look at. You give me a confidence interval, I'm going to look at that. So again repeating, I'll run through that. These examples I'm not going to talk about, but I'm going to the next this thing, which is your sensitivity and specificity, diagnostic test, RT-PCR, your RAT test, your HRT, your DCT, or something that you're going to use. So you have a 2x2 table. There is a disease. So there is no disease and it is not rejected, specificity. If there is no disease and it is rejected, that is false positive. If there is disease and it is not rejected, that is type 2 error. If there is disease and rejected, this is right, sensitivity, right? So this is what we call, so again I'll explain this. Patients without disease on that side, with disease, blood sugar le lo, ya IOP le lo, IOP higher on this side, that is on the lower on the other side. So IOP without disease and IOP with disease, bahut zyada hai. Then you call these positive, you call them negative. This is true positive, because if you see the parametric, the Bell's curve, the end of the Bell's curve is something which is positive, though it is positive, it is actually probable to be normal also. So these are false positives, this is true negative, this is false negative, and then you can have a move towards the right or left and you get what is called as ROC curves. These ROC curves tell you whether it is a good test, whether the curve is like that. The curve is flatter, it is a poor test. These are best test, these are worst test. Then you look at correlation, X and Y, whether you can correlate and you find a single line, and the correlation can tell you whether that relationship is associated, not causative, right? So you have a correlation. Then you have regression when you're using multiple data points and you're using multiple age के साथ correlation है कि नहीं, इसके साथ correlation है, drug के साथ correlation. So multiple, then you do regression. So you do multiple regression analysis, which is much more useful. And you can have linear, probabilistic, Poisson regression. I'm not going to go into that. And then last is survival analysis. When your survival analysis is evaluation from time to an event, that is death or recurrence or recovery. Drug चालू किया कितने दिन के बाद, कैंसर था कितने दिन तक सर्वाइव कर गया, right? So this provides the commonest example is Kaplan-Meier. Okay, so you have remission in group 1 and remission in group 2. So you want to compare these two. I mean, obviously this is looking, when the data is like this, it looks very nice and you don't need a good amount of statistical this thing, but this is visualization. But when you look at, is there a difference between the two survival groups? Two groups, Mantel-Hansel test or log rank test. More than 2 groups, log rank test and Mantel-Cox. All right. So finally, you will look at Bradford Hill criteria. So it is strength, consistency, specificity, temporality, biological gradient, plausibility, coherence, experiment, and analogy. So when you say that, sir, आपने वो दवा दिया था ना, उसके बाद मेरा आँख गया. So the patient is talking about temporality. You tell him, भैया Bradford Hill criteria apply करेंगे, plausible explanation है ही नहीं. टेम्पोरलिटी है, आप राइट है, स्ट्रेंथ है. सर ज़्यादा गोली खाए तो ज़्यादा उल्टी होता है, 4 गोली खाया ज़्यादा 4 बार उल्टी हो गया. ओके, स्ट्रेंथ है, टेम्पोरलिटी है, लेकिन बाकी. सो मेनी टाइम्स पीपल टेल मी दैट सुनील दिस इज हाउ इट इज. आई विल लाइक नो, इट डज नॉट फुलफिल. सो यू सी दिस इन माई फेसबुक पोस्ट ऑल्सो, Bradford Hill criteria not. So I will use this, I will use statements even in social media. So the last word, if you think my presentation was just average, it's quite all right. You're just being mean. Right? So read the signs. And thank you for coming early morning. Thank you for keeping awake. Thank you for listening. Thank you for laughing, which means you probably understood something.
And thank you, sir, for explaining things so clearly. So I next invite Dr. Dr. R.P. Maurya. Sir will be speaking on immortalize your work, writing the research paper, and submitting the manuscript. So Dr. Maurya is an associate professor and in charge of the ocular trauma, oncology, and oculoplasty unit of RIO, Institute of Medical Sciences, BHU, Varanasi in India. He is the Joint Secretary of Oculoplasty Society of South Asia and Ocular Trauma Society of India. He is the editor-in-chief of the Indian Journal of Clinical and Experimental Ophthalmology and the International Journal of Ocular Oncology and Oculoplasty. He is a reviewer of numerous journals and has multiple presentations, publications to his name. Over to you, sir.
Thank you, Dr. Subhrangshu. I'm going to talk on immortalize your work, writing the research paper and submitting the manuscript. What is research paper? Research paper is defined as a paper is a logical, systematic presentation of your finding on the particular subject. What is the purpose of writing paper? To disseminate the scientific information and knowledge acquired by experiments or observation to benefit others. Why it is necessary? Sir William Osler says that in science the credit goes to man who convinced the world, not to the man to whom the first idea occurs. It is not enough to good scientist, engineer or doctor whatsoever. You have to make other people understand what you are doing and why it is important. No matter how competent you may seem, your hard work will usually unrecognized because other will step in and communicate it more skillfully. Why paper? Why not only in conference and symposia? You can give your ideas. Writing is the best communication, having lasting impact, larger unlimited audience, and have advantage over verbal communication. How to plan to write a paper? Ask some questions. What do I have to say in my paper? Is the paper worth writing? Do you find similar paper? If yes, then forget the topic. Where to publish? Choose a perfect format of the manuscript, audience, and journal. Understand about the topic first. Study the review articles, collect various references from various search engines, attend the conference and symposia on your topic, then think about your topic. What is it? What shall be the outcome? Is it novel? Is it repetition of the previous work? First, choose the format, whether you are going to publish your manuscript in the form of original article, case report, or later to editors, review article, etc. Then prepare your research paper in area of demand or promise to make you successful. Choose a journal, whether it is a journal like Nature and Science or subject-wide, British Journal of Ophthalmology, Indian Journal of Ophthalmology, Surgical Oncology, and choose according to specialists, whether it is cell, neuron, genetics, or heart. Then choose the journal according to impact. Where to publish? In clinical science, 2 million biomedical papers published every year by more than 20,000 journals. But it is very difficult to select. So make a strategy, topic of the journal coverage. Check the website of the journal and scope of the journal. Then look it whether it is peer reviewed or not, most appropriate readership, and length of time from submission to publication. Always choose the highest impact factor journal first. Once you decide your topic and format, then get started. Prepare an outline of the paper. Start writing the easier part first. Note down the points and don't look for the accuracy of the grammar initially. Prepare graph and table properly. Outline that include introduction, method, result, discussion if it is original article. There is a challenge in publication. Even with a groundbreaking research, unless paper is correctly written, at the best publication will be delayed or it was rejected or never published. So goal should be write well-structured research paper for publication. The sequence of writing your manuscript should be method section first, figure and table, then you write the result, and after that introduction part. Then discussion according to your result, finally abstract and summary, and last you write the title. Title page that contain the type of manuscript, whether it is original, review, article, then title of the manuscript, author and co-authors affiliation, short running title, and write down the keyword, at least 5, complete contact of the corresponding author. Title, you know, it is an advertisement of your article. It should be short, simple, and eye-catching, clearly and accurately addressing your content, and do not use any abbreviations or jargon in your title. Then abstract. Reader can decide whether or not to read whole article. Interesting paper with bad abstract may be rejected. Independent document, typically a single paragraph. Word count should be limited according to the journal instruction to author. Word must be finely chiseled. And first mention the objective and hypothesis, then clearly describe your methodology, finally about the significance of result and impact of your work. In introduction, it requires a short review of the literature, maximum 2 to 3 paragraphs, and lengthy introduction means author anticipating the discussion part, so it should not be lengthy. Clearly state the problem being investigated and background that explain the problem, reason for conducting your research, and summarize the relevant research to provide your content. State how your work differs from others' work. Identify the question you are answering in your manuscript. Then comes to the method. Method preferred to use always in passive voice. Explain how you studied the problem, identify the procedure you adopted, and justify the selection criteria, that is inclusion and exclusion criteria. Explain new methodology in detail if you are first time describing, and what type of data were recorded. And avoid duplication of observation in text and table. What you are showing in table, don't describe in lengthy in your text. Then comes to the result. Objectively present your finding and explain what was found. Add the table figure useful to the better grasping masses. Table and figures should stand. Their own title should be self-explanatory. Abbreviations should be given at the bottom as a footnote, and exact p-value should be given rather than quoting that is non-significant. Then comes to the discussion. Discussion should be clear, sharp, and direct to the point of your study. Length does not translate into quality, rather it creates confusion. So discussion should not be so lengthy. Summarize the most important and remarkable finding and contrast these findings in a light other way studies. And accept or reject your hypothesis of research hypothesis. Then comes to the conclusion. The most challenging section of the writing should be attempted in the last. Language should be simple and plain. Provide strong and clear take-home message. And concentrate on hard finding. Never put your personal thoughts in conclusion. Then comes to the reference. It includes all the references that have been cited in your text. List only relevant references. Avoid references that are difficult to find. And always try to give newer and recent references. Avoid listing the self-publication in your reference. follow the instructions of to author. There are various type of references style like Harvard, Vancouver, and APA, MLA. So choose according to the instruction to author. Then finally acknowledge to your other contributors who is not as author or co-author. State all the funding source and work ensuring the statement adhere to the guideline provided by funding agency. Authorship, originality, plagiarism, and ethical consideration is very important. Submitting your paper, submit your final writing manuscript online on the portal of the journal. Journal editors first note whether the topic of paper fit in the journal or not. If it is fit, then they select peer reviewers having expertization in their subject area, and if it is not fit, they straightforward reject your article. Review is divided into two sections. One is for editor, another is for author. Decision of the acceptance is made by the editor based on the advice received from the reviewer, how well the paper fit in the journal, and the availability of the journal space. Editor's priority, always consider editor's priority. Does the work fit in the journal scope, clarity, and the English language? Is the science sound, targeted to journal? Is it new or interesting? They want these things. Then priorities to reviewers. Reviewer also wants quality, soundness of the research, suitability of the method and analysis, soundness of analysis and appropriateness of conclusion, language presentation, and contribution to the literature, whether it is a novel study or not, important, interesting to audience, readers or not. They may also comment on suitability of the journal scope and research publication ethics, everything. So there are certain reasons for the rejection of manuscript. Poor experimental design, lack of hypothesis and aim, and poor recruitment and a small sample size, short follow-up, and unjustified lacking conclusion, failure to confirm your target journal, methodology is not properly given, inappropriate statistics, and over-interpretation of result, conclusion is not supporting your data, and poor literature review. These things are the reason of rejection of the manuscript. How to overcome the rejection? A study did not examine an important issue, then go for review the literature thoroughly and clearly mention research question. A study is no interest to the journal, then carefully read the journal's aim and target journal and search other journals. Originality, similar study already done, then take a bigger sample size, better method, and different population, study population. Layout should be sloppy and drop. If poor English, then keep the sentences short, run a spell check, and innovative, and prefer the power of calculation, etc. So the randomized clinical trial are highly demanding as having highest level of evidence. Level 1, that is double-blind control, but such reports are scanty and expertise. So finally, I conclude that editors and reviewers are looking for original and innovative research that will add in the field of study. For a larger study, it may be better to produce one important research paper rather than number of average incremental papers. Don't get frustrated if the manuscript is rejected. Any attempt to reshape the draft and resubmit it to different journal is always better than dropping into the dustbin. Thank you.
Thank you so much, sir. I next invite Dr. Santosh Honavar. Sir will be speaking on the crowning glory, choosing the right journal and responding to reviewers. Sir needs no introduction. Sir is among editor of Indian Journal of Ophthalmology and Indian Journal of Ophthalmology case reports. And he is the director of Medical Services, Center for Sight Group of Hospitals, director, Department of Ocular Oncology and Oculoplasty at Center for Sight, Hyderabad. Sir, over to you.
Thank you so much. Thank you for making me part of the course. I was asked to speak on how to find a good journal for publication. You already heard that publications provide you with academic immortality, make you and your work discoverable, accessible, and more importantly, reusable. That is the purpose of publishing. But when you look at journals, there's a jungle out there. There are hundreds of journals, thousands of journals that may or may not be relevant to you, and you have to always find the right match. That starts with recognizing what is your type of article. Are you writing a photo essay or an ophthalmic image? Is it a case report? Is it a case series? whatever is the type of the article, you have to be very clear as to what type of article it is. Some of the journals accept up to 16 cases as a case series. Some journals accept up to 12. So you have to read the instructions of authors very carefully and see where your manuscript fits in. If you have a bunch of 16 cases, then you can't submit it as an original article for that journal. So first step is to recognize what type of an article it is. Then to recognize which is a good journal. Again, there are thousands of journals and you can't start with the worst journal because your manuscript may have a scope to get published in the best journal. So these are some of the criteria. Dr. Moria has already alluded to it. Journal of professional repute, which you think is being referred by your own peers and teachers. Something that is always brought into academic conversation whenever you are discussing a case or whenever you are discussing a particular management. Something of professional repute. Journal should be indexed. Non-indexed journals are okay to publish small cases and photo essays and images, but if you have an original article, if the journal is not indexed, that means that it will not be pulled up on PubMed search. It may come up on Google Scholar, but it will not be pulled up on PubMed search. So indexation is very important when you want to publish. But new journals are not indexed up to 3 to 4 years. It's a process that takes 3 to 5 years sometimes. But once the journal gets indexed, retrospectively, all the articles published so far will also get indexed. So IGO case reports, for that matter, is just 1 year old. We are on the path of indexation. It may take 18 to 24 months, right? But then IGO is a reputed journal. It is already indexed. So we have a path to indexation. But if it's a journal that is already long standing, has been there for 5-7 years, but it is not indexed, it may not be a good idea to publish it. It should be is a good journal if it's published by a professional society. Like Ophthalmology is a journal of American Academy of Ophthalmology. Similarly, IGO is a journal of All India Ophthalmological Society. If a professional society is backing up the journal and that is the official journal of a professional society, that gives it more credibility. Then it should have a reasonable impact factor. Impact factor, you don't aim at say impact factor of 20, 25, but anything which is around 2 to 5 would be good enough. Ophthalmology journals generally don't have a very high impact factor except retina research and ocular surface. There are 2 journals which are very high impact factor, but you can aim at something that is moderate. Having a journal with a lower impact factor doesn't mean that your article will not get highlighted. So we have had articles even in IGO which have had more than 300, 500, 700 citations. So your article will get recognized based on its value, not on the impact factor of the journal. That you must always remember. Publishing in a journal with a higher impact factor would give a boost to your curriculum vitae, but that does not make sure that your article also gets cited as high as the other articles published in the same journal. Your article will be cited based on its merit. Journal should be regularly published. You should not be having a journal which is publishing its March issue in July. It should come on time. Reviewer time should be compact. Anything which is 6 to 8 weeks is considered a compact review time. If the review time itself is 6 months, then your article is losing its advantage of early publication. Timely decision again. 3 months is a timely decision. 3 months from the time you have submitted, after revision, re-revision, 3 to 4 months, about 90 to 100 days is considered timely. Reasonable publication time. Again, after acceptance, it should be published in 2 to 3 months. It should not take as long as a year for it to be published. That is again going to delay. And it should cater to your targeted audience who read the journal. For example, if you've done something that is very relevant to India at this point in time, not relevant to say somebody who is sitting in Africa or Europe, so it is best published in the Indian journal, right? So if you have done some study, if somebody has done some study in Tanzania, it is better that it is published in that regional journal, which is relevant to that population. So that is also a criteria. So 3 factors which are most important, I would say, are scope of the journal based on the type of your article, reputation of the journal, which is a conglomerate of many factors, including whether the journal is from a professional organization, what is its impact factor, etc., and a cumulative turnaround time. These are the 3 criteria for scope. Does it fit to the focus of the manuscript? Does the journal regularly publish such manuscripts? And does it serve your target audience? So you should know your audience. Reputation I have already described. Now, most important is to be beware of the predator journals. There are many journals which keep sending you requests to publish. If you're published in even a single journal, they'll put you in the database and keep on pestering you to submit articles. Initially, when you get that email, they will not mention about the publication fee, which is going to be very hefty, even $1,000 to $5,000. So if you have a journal which is from an unknown publisher, which has no peer review process, promises to publish your article within a week, lightning speed, you would say, unknown editors, not indexed, not on directory of open access journals or DOAJ, has a hefty publication fee, then that is a potential predatory journal. And there are two lists which list predatory journals, BIAL's list and list of predatory journals. And if you get a request from any of these journals, please not submit a manuscript. Turnaround time already described. So checklist is that, does the manuscript meet the scope of the journal? Is the readership your interested target based on region, country, comprehensive ophthalmology versus subspecialty, etc.? Is the journal popular among your own friends and peers? Is the journal optimally visible in digital databases such as PubMed and Google Scholar? Is the journal accessible? Is it open access? Is the full text accessible? If the full text is highly paid, say $100 for full text, then that journal is not accessible. You publish it, fine. It remains somewhere and nobody will read it. And what about the acceptance rate? Okay, so you have to, sometimes it is stylish not to be matched, but it is always good to find the right match for your article. You can't bark up the wrong tree. Why IGO? IGO is a reputed national journal, official journal of AIOS. 25,000 AIOS members access IGO. It is an open access journal where there is no fee to access it from anywhere from the world. Over 500,000 online hits per month. So as we speak, every 5 seconds somebody is accessing some article published in IGO. So it has a very high access rate, high citation if the manuscript is good. As I said, some of the articles in the last year have received already 180, 200 citations. Your peer group reads it, Indians read it. And if your sphere of work is in India and you want to build a reputation as an academician or a clinician in India, it is ideal that you publish in it and residents read it. And it is a very distinguished group of editors, one of who is present right in this room, Dr. Natarajan, as the past editors. And it is always good to have this kind of a reputed lineup. It has interesting cover pages every year. It has had a huge growth in the last 5 years, 500% increase in the number of Indian manuscripts submitted. Overall increase is about 300%. Number of publications have gone up, and you can see the number of citations has gone up from 1,100 odd to about 5,000 already. Impact factor is on the rise, 1.848 now going up to 2. Site score has gone up to 2.8. So all these are very positive indices, and that is the reason why Indian ophthalmologists have trusted IGO in the last 5 years, and we've added 2,000 odd new submitters, new authors to the fold of IGO in the last 6 years, which is about 10% of AIOS membership. So 10% of AIOS membership have been brought into the fold of academicians. That has also risen the ranking of Indian ophthalmology in terms of publications from number 6, where it was, behind UK, Japan and Germany, to number 3, right behind US and China. China can be overtaken in the next 2-3 years, but US is difficult. So we are on the rise, and we have IGO case reports as well for you to publish your cases. Authors from 24, 25 countries have already published in it, and if you are a little lazy about writing up, then why not a video? You can always make a nice video in 8 minutes, add a nice commentary to it and submit it, and it is the first indexed video journal in ophthalmology. It's part of IGO. And as far as peer review is concerned, I would be very, very brief. So when the peer review is completed, you have generally 3 outcomes. Acceptance without modification is very rare, and that may happen to an ophthalmic image. Most common outcome is rejection. Of course, 70 to 80% of manuscripts are rejected. What is left, 20 to 30%, you may be asked to revise. Out of revision, there could be a major revision or a minor revision. Major revision with re-review, about 60 to 70% possibility of acceptance. Major revision without a re-review, you're almost sure that it will be accepted. Minor revision, it is nearly 100% accepted. So whenever you approach a revision, you should consider the comments of the reviewer and make a 3-column response. In the first column, your response, obviously whatever the reviewer has asked, reviewer's comment would be there in the first column. In the second column, your response will be there. And in the third column, where exactly in the manuscript your response has been there. You have modified the manuscript. So page number and the line number in the third column, and also highlight where exactly you have modified it. So this is very important because all these may go to the reviewers and you may need to convince them and also the editor. It's the peer review process is just like making up your manuscript. So it was always good, but somebody polishes it and makes it's same person that you're seeing transformed, right? So the whole process of peer review is to transform your article, though, without changing the data. Data is all the same. The way you look at it, where you have kind of dress it up is all changed. So do you appeal against a reject decision? Usually no, but if you have very strong grounds that your manuscript has been unjustifiably rejected, you can appeal. Very subtle words, but make your point clearly. And if your article is rejected, you should always have a plan B. So it's always good to fit your article to a particular journal, and definitely make sure that you submit your work. Thank you so much.
Thank you very much, sir. Now it is my privilege and honor to invite Padma Shri Professor Natarajan sir to the dais to speak on the final overview, ethical publishing, financial disclosure and plagiarism checks. Sir is the past president of AIOS. Sir has been the editor of the Indian Journal of Ophthalmology. He is the chairman and managing director of Aditya Jodh Eye Hospital Private Limited. Sir is a fellow of the Royal College of Physicians and Surgeons, Glasgow, and a fellow of the European Latino American Society of Ophthalmology. He has authored numerous chapters, published numerous articles, and been the chair and co-chair for numerous presentations. Sir, it's my honor and privilege to hear you.
Thank you. So, only thing is, I think, thank you very much. And I think after speaking, after Santosh to speak is a great problem. No? What, Santosh? And so I haven't any financial interest. So nothing is coming. So no, I don't have any financial interest, and I think so. The challenges in publishing, and publishing information from a patient-doctor relationship, editor's duty to warn of unethical clinic or a research practice, conflict of interest, open access, and global health equity. And why do ethical issues arise? Journals exist to enhance the scientific database, enhance seniority and income, pharmaceutical company profits, and publishers' profits. Points to consider: the authorship and plagiarism. I'm sorry, there's a spelling mistake here, and I have to accept that. So you have to be careful, and that's what I keep telling my own fellows. And authorship, and I think there's a COPE is the one which everybody should read, and who can be an author, an authorship order, issues and problems with the authorship. Many times I think we have seen, I'm sure Santosh will face, like there will be some arguments between the team. And I think before you start a work, you should decide the authorship. And there's an International Committee of Medical Journals Editors called the IC378. Substantial contributions to the conception and design of a paper, or acquisition of data, or analysis and interpretation of data. Drafting the article or revising it critically for important intellectual content, and final approval of the version to be published. JAMA specifically asks so many questions on this, and then when you write no, and they'll again ask, there'll be a sub thing pops up. So I think the idea is you have to be a really partner. Just because you're collecting data or just writing a reference is not, you cannot be an author or a co-author. So best practices for authorship: discuss the order of authorship at the beginning of the project, and revisit decisions on authorship during project, especially if responsibility changes, and disclose if any writing done by professional writers. document everything in writing, and all authors take responsibility for content. So that's what I learned when I became an editor, that you are honest to yourself and also teach honesty to the people, because that finally says that you may not inadvertently do and say sorry. You have to be aware of it, and how this is, and then a redundant publication. Using text or data from another paper prior publication, usually your own in a new paper, also called auto or self-plagiarism, and how to avoid. Do not include material from a previous study in a new one, even for statistical analysis. Repeat control groups as needed. And it happened to me, and I had to withdraw the paper when I found out. So even this time it happened in RO. My fellow didn't read, and I think it was already when they sent for publication. And I think this is a problem when you have turnover of fellows. They take something, and I think you have to be involved. Just because I am the mentor, and I cannot say they have done it. And famous thing is Dr. C.N.R. Rao, his own fellow, took a paragraph from his previous publication, without realizing that, and put it, and I think the international journal said, we will publish, saying that this was put like that, and withdrawn. So C.N.R. Rao, in spite of having all accolades in science with the Bharat Ratna, but it is a punishment. You have to take it. You cannot say sorry because the fellow did it. So that's a big lesson for all of us, including me, and that has happened. But luckily, every time I'm aware before the last minute. And duplication. If in doubt, always seek editorial advice. Duplicate publication, definition, submission of or a publication of the same paper or substantial parts of a paper in more than one place. And I think it's really important, because I keep telling, recheck, because the fellows who come change, and they don't even check what has happened in the last year, and that's not correct. And I think you have to, people like us, we have a reputation, and I think we cannot, that's the reason supervision is really important. And how to avoid. Do not submit a paper to more than one journal at a time. And I think, why should we, I don't know why, I think my suggestion is only one journal you have to apply, wait for the comments, and many times if it is rejected, then you can send to another paper, another journal. Wait until your paper is rejected before submitting elsewhere, and withdraw a paper if you decide not to resubmit after being invited to do so. And data fabrication and falsification, again, that's why I said honesty. So changing or making up data in a manuscript. We found that one of the author from northern India had made one particular number, and I don't know how at that time the plagiarism software was not, we couldn't use an advanced software because of the paid software. Manually, one of my editorial board members found out, and it was a ditto, and that was in a totally non-ophthalmology journal, which is something like a material science, and it was put in the Indian journal, and we had to withdraw that. I think Dr. Nayak's time, one was withdrawn, and my time, one has been withdrawn. So I think it's also a problem for the editor, because it's a reputation of the journal. And my suggestion is, I think the young people should learn to be honest. You make a mistake, but please don't fabricate. Just because your boss is writing, maybe strict, take the punishment for not doing the number or something, but don't fabricate. And never be afraid of accepting the fact. Intent to improve the results includes digital manipulation of images, plots, micrograph, etc. So how to avoid? Present the exact results obtained. Do not withhold data that don't fit your hypothesis. Don't try to beautify images with Photoshop. Any manipulation must apply to the whole image. And I don't remember which journal, they have even asked for keep the rough notes to be kept for 5 years. I don't remember which, I don't know whether it's Nature, but I think there are some journals who ask for the whatever rough work you have done, the rough sheets has to be maintained for few years, because somebody can question, particularly if it's a path breaking. An unacceptable figure manipulation, improper editing, improper grouping, improper adjustment. Authors should not move, remove, introduce, obscure, enhance any specific feature within an image. Images should appear as captured in the lab or in the. And improper editing, boxes revealed during processing for publication, removal reveals debris. And here you see the original image and the manipulated image. And then improper grouping. Authors should not generate composite images even if obtained in a single capture unless dividing lines are inserted to make clear that the resulting image was not visible in the actual experiment. And improper adjustment. you can see the original image and the manipulated image. Authors should not adjust contrast, color, balance or brightness unless applied to the entire figures, and the adjustment does not obscure, eliminate or misrepresent the originally captured information. Adjustment should be disclosed in the figure legend. So conflicts of interest, real or perceived conflict due to employment, consulting or investment in entities with an interest in the outcome of the research, and how to avoid it. Disclose all potential conflicts to the editor and within the manuscript. I think it's very important. The reason is the reader should know whether you have a conflict of interest. Really, I think because somebody is going to read the article and some treatment to be done. So if they know that their company is paying them as a consultant, I think they will take with a pinch of salt, and that's important because finally we are going to treat our own fellow human beings. And reviewer issues. Reviewers can also engage in unethical behavior, bias, conflict of interest, misappropriation of privileged information. Reviewers are obligated to maintain confidentiality, inform the editor if circumstances preclude an unbiased review or could represent even a perceived conflict, provide fair and collegial assessments. And who is an author? So an author is considered to be someone who has made this way, which is what I made in the first slides. So when it is time to publish, so the authorship, who will be the principal author, co-author, in what order of the manuscript, who should not be an author, and what journal, general or specialty journal, brief note, impact factor. I think Dr. Santosh covered. Each author should have participated sufficiently in the work to take public responsibility for the content. And this participation must include conception or design or analysis and interpretation of data or both, and drafting the article or revising it for critically important intellectual content. Final approve the version to be published. Participation solely in the collection of the data does not justify authorship, and this is published way back in 1985. Acquisition of funding, collection of data, or general supervision of research group alone does not justify authorship. And all members of the group are named as authors should fully meet the above criteria for authorship. And authorship of multi-center trials, all members of the group who are named as authors should fully meet the above criteria for authorship. And order of authors, the sequence of authors should be determined by the relative overall contribution to the manuscript. Who should be the first author, who should be the last author, and who should be the corresponding author. The order of authorship on the byline should be a joint decision of the co-authors. Authors should be prepared to explain the order in which authors are listed. Some journals now also request that one or more authors referred to as guarantors be identified as the persons who take responsibility for the integrity of the work as a whole from inception to published article and publish that information. The first author should be that person who contributed most to the work, including writing of the manuscript. Should have adapted a hypothesis, defined precise methods, participated in a major way in analysis and interpretation of results, and also written the paper. And a lead author, a person who is responsible for ensuring that all authors review and approve the final version. Co-author should have made significant contributions to the planning and execution of the research, the methods and procedures, the collection and analysis of the data, etc. And order of author's name. It's a common practice to have the senior author appear last, sometimes regardless of his or her contribution. There are two positions that count, first and the last, and attached to either position is the status associated with the being the author for correspondence. All contributions who do not meet the criteria for authorship should be listed in an acknowledgement section, who provided by purely technical help, writing assistance, department chair who provided only general support, financial and material support. And what does not count? Supervision of the first author, chair of department, chief of division, director of lab, etc. Statistical advice alone, data entry, processing or management, providing or helping obtain space, money, staff or other resources. The senior authors sometimes take responsibility for writing the paper, especially when the research student has not yet learned the skills of scientific writing. The senior author then becomes the corresponding author, but should the student be the first author? Some supervisors put their students first, others put their own names first. Perhaps it should be decided on the absolute amount of time spent on the project by the student in getting the data and the supervisor in providing help and writing the paper. Or perhaps the supervisor should be satisfied with being corresponding author regardless of time committed to the project. And how to avoid problems with authorship. Agree with your collaborators that you will follow the international guidelines. And I agree before starting the research, and that's what I'm repeatedly telling, who will be an author, and if necessary, discuss why each person should be an author, clarify the requirements. agree on the tentative order of authors and who will be corresponding author. Don't add a senior author to improve the chances of publication. An author's contribution versus contributors. In reality, the best that is usually achieved is each author offers a specific expertise and all authors comment on the final draft of the manuscript. Only the primary author is truly involved in all aspects of the study. And the use of word plagiarism in the English language dates back to 1600. It is derived from the Latin word plagare, which means to kidnap. So the deliberate or reckless use of someone else's thoughts, words, or ideas as one's own without clear attribution of their source. In scientific writing, plagiarism is regarded as a serious breach of ethics. Authors have responsibility to ensure that they make due acknowledgement every time they use the ideas or words or others. Editors of scientific journals also have a responsibility to discourage plagiarism. So the copyright infringement, the plagiarism, and then avoiding plagiarism is always not easy. For the next paper, next session. Yes. Okay. So I'm plagiarism of ideas, plagiarism and mosaic plagiarism. There are several plagiarism. You can see Jason Blair, New York Times, and this is a famous Farid Zakaria was punished for plagiarism. I mean, you can't copy your own things, and I think so. The main thing is there are anti-plagiarism software. So main thing is you have to be honest to yourself, and I think. A medical reader should avoid writing multiple separate articles if he can present a large complex study in a cohesive manner in a single article. So I think the main thing is you have to, last but not the least, if he feels he has unintentionally used somebody else's idea or text without appropriate reference, he needs to write to the editor of the journal for advice. Confession is always better than to be caught stealing. So I think even if you don't know that I think you have to be aware. So this is what I want to conclude and thank Subhrangshu for giving me this opportunity to talk this subject, because this is what I keep daily talking to my students. Thank you.
Thank you, sir, and thank you all the co-instructors and all those who took time out to attend this session. I hereby conclude the session and hand over to the next chairperson.